Welcome everyone to this session. If think you're in session C, Infectious Diseases and Harm Reduction, you're in the right place. If you're not, we won't take it against you if you leave. My name is Gisela McPhail. I'm an infectious disease physician in Calgary, Alberta, Canada, and I'm pleased to co-chair with
Brendan Jacker, clinical epidemiologist at the University of New South Wales in Sydney.
Right. So just for some housekeeping notes, please visit the discussion space in the exhibition for the session Integrating Hepatitis B Responses into Harm Reduction, Advocacy Needs and Actions at 3 p.m. Wait a minute, that's going to be a problem, but we encourage you also to participate in the poster tour starting at 3:10, and you can collect headsets in the exhibition area and view the details of the tours in the handbook or the conference app. And don't miss the final session called Supervised Drug Consumption Facilities Examining the Paradox in Room D here at 5:10. Leave it to you.
Fantastic, thank you so much. So welcome, folks. We are excited to introduce Dr. Adelina Ateni as our first presenter today. Adelina is an epidemiologist, and her research is focused on the prevention of hepatitis C, HIV, and other drug-related harms. She is a postdoctoral fellow based at the University of Bristol, where she explores strategies for measuring and reducing HCV transmission in different risk groups using epidemiology and modeling. Thank you, Adelina.
Thank you very much, Brendan. Am I supposed to see my slides here?
What was that?
Good question.
Am I supposed to see my slides here? Because
you should.
Or should I have my...
Can you see them there, Adelina? Can you see them there?
Right.
Will that work for you?
Yeah, that makes sense. Okay. Okay, thank you very much. And hi, everyone. Thanks for being here today. So I'll dive right into it. Actually, before I begin, I wanted to point out that the work that I'm presenting today is the product of a very large collaboration, and I'm thankful to a lot of people who have contributed to this work, not only mentors and colleagues at the University of Bristol, but also to our external collaborators and partners who provided and published data to be included in this review. Okay, so I think many of you here know that people who inject drugs are one of the populations most affected by HIV and HCV infection. And because we have very effective prevention and treatment strategies for both of these infections, UNAIDS and WHO have recommended policies and targets for ending these infections by 2030. So the terminology differs a little bit. The target is to end HIV/AIDS by 2030 and eliminate HCV as a public health problem by 2030. But the end goal is very similar, to reduce transmission of these infections to very low levels. And one of the implications of these policies and targets is the need to measure and keep track of the HIV and HCV epidemics, particularly in people who inject drugs, because they are one of the highest risk populations. And incident infection for HIV and HCV can be more difficult to measure than prevalence, but it is key to measure for several reasons, and that includes for monitoring the scale and the course of these epidemics, so knowing where the epidemics are going, for informing the need for interventions and evaluating impact, and then finally alluding to what I was just referring to, incidence is important for tracking progress towards the 2030 targets. So with that in mind, our goal was twofold. The first was to systematically review and synthesize global data on the incidence of HIV and HCV infection in people who inject drugs. So we wanted not only to quantify the levels of transmission, but also to map the scope of available data, how many countries measure incidence, seeing this is one of the main metrics to validate the 2030 targets. And then second, we wanted to synthesize data on the relationship between age and sex or gender and the risks of HIV and HCV acquisition, given there is quite a bit of literature suggesting that women and younger individuals have a higher risk. So we did a systematic literature search of several databases. We've included studies published between 2000 and 2022. We imposed no restrictions on language or design. However, we were more strict in terms of how the outcome was measured. So first of all, we've only looked at primary infection, and second, we've only included studies that measured incidence either through repeat testing and follow-up of people at risk, or using assays for recent infection. So any study that used modeling or prevalence to estimate incidence was not included here. So the study had to be focused on people with a history of injection drug use. In terms of data extraction, in addition to extracting incidents, we've also extracted a number of characteristics at the level of the study and at the level of the participants, because we were expecting to see quite a bit of heterogeneity in incidents, and so we wanted to use this information to understand some of the differences. And finally, we've used standard methods for assessing risk of bias, and then random effects meta-analysis and meta-regression to analyze the results. So this is showing the study selection criteria. I won't go over it in detail, but one thing that I wanted to point out here is that in addition to published literature, we've also reached out to a number of collaborators who we know are doing work in the field of HIV, HCV, to ask if they have unpublished data to be included in our review. So about a quarter of the estimates are unpublished. So this slide is showing the results for HIV incidence, and I know you can't see the forest plot, so I'm just going to point out a few key findings. So we identified a total of 64 estimates. This is globally. Most came from prospective studies with convenience-based recruitment. The median risk of bias score was 6, which was indicative of moderate risk of bias. In terms of the geographic distribution, so 27 countries had at least one estimate of incidence, and except for one study done in a low-income country, all other estimates originated from high or middle-income countries. And also important to mention, 2/3 of these estimates were derived from single cities within a country, so they're not necessarily nationally representative. In terms of the time period, by design, because we were inclusive in our inclusion criteria, estimates were measured anywhere between 1987 up until 2021, and as you can see, quite a significant proportion were not necessarily recent. In terms of the actual range, incidence ranged between 0.1, less than 0.1, to a high of 31.8 per 100 person years, so there was a lot of variability, and the pooled estimate was 1.7 per 100 person years with considerable heterogeneity. This slide is showing the results for HCV incidence. Many of the characteristics in terms of the design of the studies, the time period over which these were measured are very similar to those for HIV incidence, so I'm not going to repeat those. One of the things that we noticed is that there was a lot of overlap in terms of the countries that measured HIV and HCV incidence, so it's oftentimes the same country that measures both of these indicators. And the other important point is that 79% of estimates came from high-income countries. So again, a considerable geographic skew in these estimates. And there was even more variation in terms of the range, so from 0.2 per 100 person years to 72.5 per 100 person years, and the pooled estimate was 12.1. So I mentioned earlier that we were interested in exploring some of the sources of heterogeneity. This is only showing a few select results, and I'm not going to go over them in detail, but the point was here to say that we did find that incidence varied a lot by the methodology of the study, how participants were recruited. So for example, we found that studies in which participants were recruited through medical settings had generally lower incidence compared to studies in which participants were recruited through participants' network using RDS samples, for example. So then we were interested in knowing, is there anything that can be said about geographic and temporal differences in incidence? So I have to say that this analysis is very exploratory and it has a lot of limitations, but it does provide some important insights that could be explored further in future research. So when we looked at differences by geography, here defined as the economic level, what we found is that for HIV, incidence was 2.4 times higher in low and middle income countries compared to high income countries. For HCV, we did not find a difference by economic level, but as I mentioned earlier, 80% of estimates were from high income countries. So there just wasn't enough variation in distribution of these estimates to capture any differences if there were any. In terms of trend data, we did not find any trends over time for HIV incidence, but we did find that HCV incidence declined by 20% on average per 5-year period. We were also interested in looking at the ratio of HCV to HIV incidence. So there was a subset of studies that had measured both of these indicators on the same population over the same time period, which allowed us to look at this. So here we found that HCV incidence was on average 17 times higher than HIV incidence, but as with all of the other indicators, there was a lot of heterogeneity around this pooled estimate. And for example, this ratio was much, much smaller in Southeast Asia, where it was close to 3, and much higher in the Western Pacific region, where it was close to 60. And finally, we were interested in looking at differences in incidence by age and gender. So this slide is showing the results for age. And as you can maybe see from these forest plots, aside for a few exceptions, most studies found a higher risk of infection for younger individuals. And when we pulled all of these studies, we found that younger individuals had on average a 50% higher risk of both HIV and HCV acquisition. When looking at these results, but now by age, we found that there was a bit more heterogeneity from study to study. But even here, when we pulled all of these estimates together, we found that women generally had a 40% higher risk of HIV infection and a 20% higher risk of HCV infection. So in conclusion, a couple of findings. So the first important finding, I think, of this review is that empirical estimates of HIV and HCV incidence in people who inject drugs are generally limited globally, and specifically referring to estimates based on what we refer to as direct methods, because we did not include modeled estimates, for example. And there is a preponderance of studies from certain regions and very few estimates from others, like low-income countries. So the available data provide, unfortunately, an incomplete description of the current global levels of HIV and HCV incidence in this population. The other finding is that the data that are available suggest that the levels of incidence are high in this population. So this suggests that, so it emphasizes the need to monitor the epidemic of both HIV and HCV transmission in this population. Now, the direct methods for measuring incidence are often seen as the gold standard or the preferred option for measuring incidence, but these are not without limitations. Oftentimes they're costly, there are limitations related to losses to follow-up. So some settings that may not be able to use direct methods for measuring incidence, they may consider using alternative methods, like estimating incidence based on prevalence, or even using other indicators to keep track of the epidemic. So, for example, in a recent modeling paper done by our group at the University of Bristol, we showed that changes in chronic prevalence track well changes in incidence in a population. So some countries may consider using chronic prevalence as a way to monitor progress towards the 2030 targets. And finally, because we found that women and younger individuals generally have a higher risk of infection, I think the study also suggests that maybe we need to think a little bit more about how the prevention programs and the harm reduction programs are set up to be able to better engage these higher risk populations into care. And the paper was published earlier this year. If you're interested in knowing more, it's available online. Thank you.
Great work. The paper's open for questions. You can either use your microphone. You've got a button at the middle of your microphone that you can ask questions, or you can put it on the conference app and we'll ask it from here.
Hi, yes, thanks. Ben Eckhart from NYU School of Medicine in Bellevue. Quick question. I don't disagree with the hepatitis C being a higher incidence in young individuals, but my concern is sort of the number, in the sense that you only included people who had incident infection as opposed to including people who had reinfection. So to me, it seems like as they get older, your prevalence is increasing and the denominator that could have an incident infection would actually decrease, and how you might sort of rectify that.
So are you saying that reinfection may be possibly as high or higher in older individuals, just because so that's
similar.
That's
yeah, exactly. If you added on reinfection onto it, the age gap between younger and older would sort of maybe not be there, although I don't necessarily agree with that either.
Yeah, I think that that's definitely true. I think the importance of looking at primary infection is that it's telling us that the rate of infection is so high within the first few years after initiating injection. It's just telling us that there's a small window of opportunity to intervene. Yeah, I agree.
That's a great question. Thank you so much, Adelina. We're going to move on to our next speaker. Our next speaker is Peter Vickerman. Professor Vickerman is a professor of infectious disease modeling. His research focuses on using modeling to assess the transmission of infectious disease and the impact and cost effectiveness of prevention measures amongst key populations, such as people who have HIV and hepatitis C among people who inject drugs.
I'm a bit visually challenged and this screen isn't working.
Oh.
But I will try and do it from that. It's okay at the moment. So thank you for allowing me to present. I'll be presenting some work we've been doing over the last number of years, modelling the impact of interventions on HIV transmission amongst people who inject drugs in Russia. And it's important to recognise that this work is in progress, and I'll be presenting some of the steps that we've been going through to be able to do this. So, the Eastern European and Central Asian region is the only region where the HIV burden is still increasing. The burden of HIV infection in that region doubled over the period 2010 to 2019. We've estimated in 2019 that there's 1.7 million people infected in that area. Most infections in that region are in Russia. So in 2021, Russia estimated that they had 1.1 million diagnosed infections, which translates to a prevalence of over 1%. If we look in the European region, in 2021, Russia made up the majority of infections in the whole European region, 58,000 compared to a total of 106,000. Now, Russia has a very large population of people who inject drugs. Although this is uncertain, it's estimated that there's over 1 million people inject drugs in the country. And if we look at a recent systematic review, which was presented earlier today, there was estimated about 600,000 people who inject drugs are living with HIV in Russia, which actually makes up 28% of the global HIV burden amongst people who inject drugs. Now, HIV treatment and intervention coverage are low in the region, in the country. And if we look in 2018, there was estimated that 45% of diagnosed people in Russia were on ART. So, this analysis follows on from a previous analysis that we did and published in 2022. In this analysis, we looked at 4 countries in Eastern Europe and Central Asia, and we looked at how much money could be saved from decriminalising drug use and what could be achieved from reinvesting that money into scaling up interventions for HIV. And we were able to show that this could majorly reduce the HIV epidemics amongst people who inject drugs in Eastern Europe and Central Asia. Now, we wanted to model Russia as part of that, but it was seen as too big a job at the time. But this sort of carries on from this, that we wanted to still model Russia. So what we've done is two things I'll present in this analysis is firstly, I'll present some of the data we synthesized for the Russia HIV epidemic, because I think this is quite informative in itself. And then I'll describe some of the modeling we started to do with that synthesized data to look at the impact of current interventions, the potential detrimental impact of the war on intervention impact, and what is needed to control that epidemic. So we've synthesized data from a number of different sources. The main source, though, was available biobehavioral surveys, or IBBS surveys, I'll call them from now on. We managed to source and get reports or data from 40 biobehavioral surveys from Russia over the period 2000 to 2017. This included surveys undertaken in 19 different cities, with 11 of those cities having more than one survey. We used these surveys to get data and estimates on HIV prevalence, levels of incarceration, the coverage of harm reduction, NGO or non-governmental organisation interventions, and HIV treatment coverage. We also was able to locate and source data from the HIV Sentinel surveillance in Russia over the period 2017 to 2020, and we are currently gathering harm reduction intervention coverage data. So this presents available HIV prevalence data for Russia, which we've included in the forest plot, and we've done a meta-analysis for 4 different periods of time, with the time of each period becoming more recent as you go down the forest plot. What the data seems to show, if you look at the diamonds, is that HIV prevalence was fairly stable over the first 3 time periods, but then possibly in the IBBS in 2017, there was an increase in prevalence. So we also have sentinel surveillance data for 2017 to 2020, a period where we don't really have data from biobehavioral surveys. Now, this sentinel surveillance includes tests of over 45,000 people inject drugs each year across over 70
Somebody
regions
has
of
their
Russia.
microphone on. Can you just check your microphone buttons? Thanks.
So if we look at the data from that sentinel surveillance for 2017, it includes the cities that which were also in the biobehavioral surveys undertaken in 2017. And if you look at those 6 different cities, the prevalence of HIV in the biobehavioral surveys is 59%, whereas in the sentinel surveillance it's 37%. Now, we hypothesize that sentinel surveillance may underestimate HIV prevalence because they're unlikely to test people that have already been tested before, whereas in a biobehavioral survey, they will test everyone that they recruit. Now, we found when we compared the HIV prevalence in the biobehavioral survey to the sentinel surveillance data, we find that there's a relative risk of about 0.62 between the HIV prevalence estimates. And we used that relative risk to adjust the sentinel surveillance data for 2017 to 2020, as shown in the little table here, which suggests that the HIV prevalence over those years was about 40% or just over. So this slide shows incarceration data for Russia. So we were able to get data from a number of different settings, and we combined them for the same 3 time periods as we did for HIV prevalence. And what this data seems to show is that incarceration has increased over time. Overall, as you compare the diamonds in the meta-analyses, but also if you look at specific settings. So this shows data of prevalence of ever incarceration for Moscow, which increases over time, and this shows it for Ekaterinburg, which also increases over time. We also found that incarceration increased over time when we stratified by duration of injecting, but I haven't shown this here. We were also able to get HIV prevalence by whether people were ever incarcerated or never incarcerated, and we had 16 estimates over the period of 2003 to 2014. And what we found is that if a person has ever been incarcerated, their odds of HIV infection are 1.7 compared to those people that have never been incarcerated, suggesting that incarceration may be increasing the risk of HIV transmission amongst these people. So this presents ART coverage data, and it's important for people who inject drugs, and it's important to recognize that this is quite limited because it's only based on self-reported data, but this is all that we have. So this is, we've asked within biobehavioral surveys, were you on HIV treatment? And looking at those people that are HIV positive to see the proportion that said they were on HIV treatment. And this suggests that there has been a scale-up in coverage, but if you look at the bottom diamond, the coverage in 2017 was only 26%. And we don't have any estimates after that date. Lastly, in terms of data, we also have data on harm reduction coverage over time. Now this, if we look at data from biobehavioral surveys, this suggests that the coverage of harm reduction interventions is highly variable. So if you look at the period between 2014 and 2017, estimates of harm reduction coverage were between 9 and 47%. Now, we think these estimates could be biased. So we do have estimates from another source. If we look at the reviews undertaken by Degenhardt and et al., they have an estimate of 34,000 clients attending harm reduction interventions in 2016. Now, if you look at what this means, if we assume a population of people who inject drugs of 1 million, this suggests a coverage of harm reduction of 3.4%, which is a lot lower than reported in the biobehavioral surveys. Now, even though the data suggests low coverage, there is evidence that the harm reduction interventions are having benefits in this setting. If you look at people in contact with harm reduction interventions in the biobehavioral surveys, they report injecting with more sterile syringes, they have lower HIV prevalence, they have a lower chance of recent HIV infection, and they have a higher rate of being tested in the last year. There's also possibly a higher ART coverage amongst those people in contact with higher harm reduction interventions, although we don't see the same association in all cities. Because of this, in the model, we assumed that harm reduction interventions do have HIV efficacy, and we did assume that they could improve ART recruitment. So in terms of the modelling, we adapted a previous dynamic HIV transmission model, the one that we used in the Lancet HIV article. This model incorporates HIV, HIV treatment, incarceration, and harm reduction status. And we used a data synthesis to calibrate this model within a Bayesian framework, and we actually used the precise estimates from the meta-analyses within that calibration. And we've used this model so far to estimate the impact of current interventions in Russia, and we've looked to see what the potential effect of the war could have been. So these figures on the right show the model projections over time for HIV prevalence in the top figure and HIV incidence in the lower figure. In the top figure, we also have estimates of HIV prevalence from our meta-analyses, suggesting that HIV prevalence has increased over time. The model suggests that it increased to about 2012, with HIV prevalence after that point, or in 2022, being about 40%, and HIV incidence being about 11 per 100 person years in 2022. The model suggests that each year there's about 100,000 new infections in Russia amongst people who inject drugs. The figures also show the potential impact of removing some of these interventions, and we look at this to see what impact those interventions have had. Now, if you remove harm reduction interventions, our model suggests that HIV incidence would be 10% higher in 2022. If we removed HIV treatment, then the model suggests that HIV incidence would be a third higher, or 33% higher. And if we remove both interventions, so both HIV treatment and harm reduction interventions, then HIV incidence would be 44% higher. And we estimate that these three interventions in 2022 prevented 20,000 infections. So this slide gives some estimates of potential impact that disruptions in intervention activity may have had since the war. So there is some evidence that the war has disrupted NGO harm reduction services, and that there has been a disruption in the initiations of new people on ART. Now, we look to see what impact would it have if NGOs ceased or scaled back. And this is shown in this figure here. It gives the estimates of the percentage incidence increase by different successive years. And we find that if it has disrupted harm reduction interventions, there'll be a small effect because the coverage of these interventions is small. And we think that incidence could increase by about 5%. Now, if there was no new initiations onto ART since the war, it says 155 here.
Oh, sorry.
If ART initiations stop, then impact accumulates and there's a larger impact. It suggests that incidence could increase by 15% by 2025. And lastly, if both of those scenarios occur, so there's a ceasing of NGO activity or a scale back or ART initiations stop, then you could have incidence increasing by 23% by 2025. So, our model projections suggest that only HIV treatment is currently having any sort of substantial impact in Russia. Harm reduction coverage is low, and that's preventing it from having a large impact. Saying that, our model projections could be being optimistic on the level of coverage of harm reduction interventions. We think the IBBS data could well be biased. We're currently synthesizing data of harm reduction NGO outcome data to get better coverage estimates. Now, through this, we're estimating the number of clients seen by harm reduction interventions each year. This suggests that coverage is much lower for harm reduction interventions than suggested by the biobehavioral surveys. It also suggests that coverage has changed over time, But unfortunately, the data we have is currently patchy, so it's difficult to use. We plan to complete synthesizing this data, and it's been taking a while, but I think we're getting there, to make a better estimate of the impact of services and how that's changed over time. Specifically, there's interest within the country to assess the impact of the decreases in harm reduction funding that occurred from around 2010 and how much effect that has had on the epidemic. We also want to look at what is needed going forwards to achieve greater impact. Thank you.
Fantastic. Thank you so much, Peter. That's a fantastic presentation. We have a moment for one question from the audience, if anyone has a question for Peter.
And remember, you can always catch people in the coffee break too, because we haven't had a lot of time for questions.
Fantastic. We might actually move on to the next presentation of Jack. Thank you very much, Peter Vickerman. So the next presentation is Jack Stone.
Excuse me?
Jack Stone's presenting.
Sorry? Excuse me?
Oh, yeah, sorry.
Yes,
Apologies.
I'm here.
Oh, sorry, I'm so sorry. Peter, we might have to be back. Thank you.
Just a very quick question about the IBBSS. You say that the data is biased. Yes, I'm here. This is Nahla Gamaleddin, WHO Egypt country office. Now we are currently conducting the IBBSS. This is the second round because the first round was in 2014. It's outdated, actually. Now we are currently implementing. The data collection is now on the ground, but we didn't have yet the results finalized. But may I ask you why you said that the data in the IBBSS was biased in your study or in your presentation? You said the data is biased.
Well, I think it could be biased, because I think generally IBBS surveys are done in settings where there is some services. And because services are so patchy in Russia, it will be ignoring areas where there is no services for people who inject drugs. And what especially seems to have happened in Russia is interventions open and then they shut, and then they open and they shut. And I think that can cause a special problem, that they're having these snapshots in these places where services then shut, and who knows what might have happened after that.
That's why you mean the geographical coverage? Yes, okay.
Thank you.
Thank you so much. Thank you.
Fantastic. Thank you for the question. Thank you, Peter. So we invite Jack Stone to join us today. Jack will be presenting on behalf of his colleague. Jack is a research fellow of infectious disease mathematical modelling at the University of Bristol. His research focuses on the use of modelling to help understand transmission of different infectious diseases and the impact and cost effectiveness of prevention and treatment measures. Thank you, Jack.
Thank you. So, hello everybody. So I'm presenting today on behalf of Kennedy Mutai, a PhD student at the University of Bristol and Cape Town, who unfortunately couldn't be here today because of visa reasons. So I'm presenting on his modelling of homelessness and HIV transmission among people who inject drugs in Pretoria. There are the acknowledgements. So South Africa has the largest HIV epidemic in the world, and prevalence amongst the general population is quite high. But despite that, our recent modelling has shown that the unmet prevention and treatment needs of key populations still contribute substantially to ongoing transmission in the country. So the national population size estimates for people who inject drugs are around 70,000. And in Pretoria itself, this is between 8,000 to 25,000, with HIV prevalence estimates going up as high as 58%. An estimated 45 to 67% of people who inject drugs report being homeless in the last year, and this is much higher than the global average, which is 22%, so 2 to 3 times higher. Global studies have suggested that people who inject drugs who are homeless are more likely to engage in high-risk behaviors and also experience barriers to accessing treatment and care. A systematic review from a few years ago showed that people who inject drugs who are homeless have a higher risk of acquiring HIV by between 23 and 95%. And then some modelling that we did linked to that review suggested that this increased risk could contribute 2 to 15% of all global HIV infections among people who inject drugs over the next 10 years. So what we wanted to do in this project was to estimate the contribution of homelessness to ongoing transmission among people who inject drugs in Pretoria, estimate the impact of existing interventions, and then the impact of scaling up those interventions or reducing homelessness. So we developed a mathematical model, which is dynamic and deterministic, which stratified the population based on demography, so by sex, race, and homelessness, by HIV infection stages, susceptible, acute infection, latent infection, pre-AIDS and AIDS, HIV treatment, or ART, and harm reduction, so whether people are accessing needle and syringe programs and opioid agonist therapy or not. That should say data sources, so we primarily parameterize and calibrate the model using data from cross-sectional biobehavioral surveys among people who inject drugs, so 1 from 2013 and 2 from 2017. We also use cross-sectional household surveys among the general population. There's 5 of these spanning 2002 to 2017, as well as programmatic data on the number of people who inject drugs accessing OAT and NSP in Pretoria over time. So based on some other work that Kennedy has been doing as part of his review, analyses of these household surveys, we assume that the population size of people who inject drugs is increasing over time. So his analyses suggest that opioid use has increased 5-fold since 2002 in South Africa, and we also see similar increases in other illicit drug use as well. So the population size is assumed to increase over time up to a value between 8,000 and 20,000 in 2021. The model incorporates both sexual transmission and transmission through the sharing of injecting equipment, and sexual transmission can occur between people who inject drugs or also with the general population. Sexual risk amongst people who inject drugs varies by sex and race, so this is incorporated based on analyses of the cross-sectional surveys, so differences in condom use, but also numbers of partners. And then injecting risk varies by race and homelessness. So we use our global systematic review estimates for the increase in risk if homeless, so 23 to 95% higher. And actually we did some analyses of the cross-sectional biobehavioral surveys, which also suggest that injecting risk is higher among homeless people who inject drugs in Pretoria and in other settings in South Africa. And then for the race, we find that those who are Black South African have a much higher risk of needle sharing. So we incorporate that in the model. So an 1.82 to 4.79 relative risk. So we calibrated the model using Bayesian methods. So this allows us to capture uncertainty in both the data and model parameters and propagate that through to model projections. And we calibrate the model to the population size, proportion of people who inject drugs that are homeless by sex and race, the HIV prevalence among people who inject drugs, and also the differences between sex, race, and homelessness, the numbers accessing harm reduction, as well as ART coverage. We then use a calibrated model to first estimate the contribution of homelessness to HIV transmission. So this is what we call the transmission path, or TPath. And this is done, this is estimated as the proportion of new HIV infections averted between 2023 and 2030 if this increased risk associated with homelessness could be removed. So that's setting the relative risk to 1. We then assess the impact of existing interventions. So in 2022, the ART coverage amongst people who inject drugs is 18%, OAT 12%, and NSP 64%. And here we look at the proportion of new infections averted by each of these interventions or in combination in the last year. And then we look going forward what the potential impact could be of scaling up these interventions or reducing homelessness. So we scale up ART to the UNAIDS 95-95-95 targets, which is equivalent to increasing coverage from 18% to 90%, so a very large increase. Scaling up harm reduction, so OAT coverage from 12% to 50%, and NSP from 64 to 75%. And then reducing the proportion of people who inject drugs who are homeless by a relative 25% or 50, so a quarter or half. And then what would the impact be of doing all these things together? And then because ART and OAT coverage is quite low, and so these scale-ups are quite big, we also consider the impact would be if only half of the scale-ups would be achieved by 2030. So this figure shows the projections for HIV prevalence over time amongst the different groups. And we can see that the model compared well with the calibration data. Aligning with the data, the model projects higher HIV prevalence amongst females compared to males, and also Black South Africans compared to other races. The model also suggests that most new infections are acquired through injecting drug use, so 88%, but there is a difference by sex. So whilst 92% of new HIV infections among males is through the sharing of injecting equipment, amongst females it's 48%. So most of the new infections among females is acquired through sexual transmission. So this figure shows the TPAF of homelessness. So this is the relative reduction in the number of new HIV infections if we could remove the risk associated with homelessness. And we see this could avert 34% of new infections over the next 7 years. Or in other words, homelessness and the increased risk associated with homelessness is contributing a third of new HIV transmission. But what we see is that the impact is much lower among female people who inject drugs than males, so the red bar versus the blue bar. And there's a couple of reasons for this. The first is that homelessness in the model is increasing injecting risk. And as I just said, most transmission amongst females is through sexual transmission. But the other reason is that homelessness is much more common amongst males than females. So between 48 and 70% in males and 26 to 48% amongst females. So these figures show the proportion of infections averted in the last year by interventions. And the first highlighted bar shows all interventions combined. And what we can see is that these have had a significant impact, averting 57% of new HIV infections in the last year. But this is mostly due to high NSP coverage, which was 64%, so this yellow bar. When we look at the impact of OAT and ART, they're actually having quite a low impact, and this is due to their low coverage. And another thing that is worth noting is that across all of the interventions, the impact is much lower amongst female people who inject drugs than males who inject drugs. When we project forwards the impact of scaling up interventions, if we first look at the impact of reducing homelessness, we find this could avert 6% or 14% of new infections over the next 7 years, depending on whether it's reduced by a quarter or half. In contrast to that, scaling up interventions, so this is the full scale up to 90% ART, 60%, 50% OAT, and 75% NSP. This could avert nearly 2/3 of new infections, so 63%. And then if homelessness is also reduced on top of scaling up these interventions, the impact only increases by 5%. Again, the impact of scaling up interventions or reducing homelessness is much lower among females than males. This slide shows the impact of this half scale up, so 55% ART, 35% OAT, but NSP to 75%. We now find that this scale up would only avert 40% of infections over the next 7 years, but now reducing homelessness on top of this scale-up has much more impact, averting 18% more, greater impact than just scaling up interventions. So to conclude, we find that homelessness contributes substantially to ongoing HIV transmission, so 1/3 of new infections, much more than our global estimates. We find that historical interventions have had a substantial impact to date. So needle and syringe programs have had the highest impact because of the high coverage. But by themselves, HIV treatment and OAT have had moderate impact due to their low coverage. We find that scaling up ART and harm reduction is likely to have a large impact on HIV transmission, averting 2/3 of new infections if a full scale-up can be achieved, and 40% of new infections if only a half scale-up can be achieved. And we find that reducing homelessness on top of these interventions can be impactful, especially when high coverage targets cannot be achieved. And thank you on behalf of myself and Kennedy, and there's Kennedy's email address if you have any questions. And I can also answer questions.
Fantastic. Thank you, Jack, so much for your wonderful presentation. We don't yet have any questions in the app. As a reminder, you can go to the conference app and leave a comment in this session that we can read out, or otherwise you can raise your hand and turn your microphone on. So any questions for Jack at this stage?
Jack, question for you. In Canada, we have a real push for housing first. Your data suggests that maybe we should be doing harm reduction first. What do you think of that?
Well, I think I would argue you do both at the same time. I think they're not necessarily exclusive. And some of the research that we've done, is showing that homelessness has this can have a quite substantial contribution. But I think we don't quite yet understand why that might be, but also whether just providing housing is sufficient to reduce that increased risk associated with homelessness. And it's something that at Bristol, with other collaborators, we're going to try and sort of look at over the next 6 to 8 years.
Any other questions for Jack?
Fantastic. Please thank Jack Stone for his presentation. And up next, we have Dr. Daniel Bradshaw. Dr. Bradshaw is a consultant virologist in the Virus Reference Department of the UK Health Security Agency, with an interest in viral hepatitis, HIV, and HTLV. He is a clinical lead for the HCV Whole Genome Sequencing Service. Please welcome Daniel Bradshaw.
Thank you, and thanks to the organisers for inviting me to give this talk, which is entitled An Outbreak of HIV and Hepatitis C in Young People Who Inject Drugs in Belfast, linked to cocaine injecting. And I should acknowledge all the co-authors, but particularly Sarah Arnold, who unfortunately couldn't be here today to present. So this was an outbreak that was first detected in July 2020, and it was detected through phylogenetics. So Northern Ireland sends all samples from newly diagnosed people with hepatitis C for whole genome sequencing as part of a clinical service, and we provide the viral subtype and resistance pattern in real time. But unlike all other parts of the UK, because it does this for all patients diagnosed, there's high density population coverage. And as part of the sequencing pipeline, the sort of quality control processes, phylogenetic trees are generated. And these involve the current run, which are shown in the tree on the right in blue tips, with 5 previous runs, which are shown in red tips, and then reference sequences in the black. And one wouldn't normally expect, obviously, to see clusters, and that would raise alarm bells about, for example, a lab contamination. But what was noted by the scientists at the time in July was that there were 25 tips all closely clustered together, and they all apparently came from Northern Ireland patients. So that rang alarm bells and was reported back to the Public Health Agency of Northern Ireland, who then instituted an outbreak control team. So the rest of the kind of data from this presentation is taken both from the phylogenetics, but also from the enhanced questionnaire surveys that were instituted as part of the response, as well as data from the unlinked anonymous monitoring survey in people who inject drugs. And that's an annual survey which provides data on viral hepatitis, HIV incidence and risk behaviours in people who inject drugs. So if we now move on to mid-2023, there are now 9 clusters involving about 466 patients, which is 40% of the total number of newly diagnosed people in Northern Ireland with hepatitis C. 6 of those clusters are 1A. There's 1 2B cluster and 2 3A clusters, and there are also 8 individuals who've got dual infections. So some of those are so dual subtype, and there are others that have got mixed subtypes. The largest cluster, Cluster 2, has now got 191 individuals. There are a couple of individuals in the clusters who are not from Northern Ireland, and the earliest sample date of any of the clustering samples appears to be 2016. So almost all of the individuals had a history of injection drug use, and then about half also had experienced homelessness and or contact with the criminal justice system. So looking at the epidemiological curve for that large cluster, Cluster 2, and you'll note that the number of cases per quarter sort of is consistent or even increasing, and that's despite some of the interventions which I'll show you in a subsequent slide, showing that they may not necessarily have been completely effective so far. So most of the individuals have got Belfast postcodes, so linked to the capital of Northern Ireland, and about 2/3 were young males. And interestingly, there were 16 individuals who had HIV co-infection, and these appeared to be incident HIV cases as well. So one of the sort of key findings from the Unlinked Anonymous Monitoring Survey, and in view of time, I'll just go through this quite quickly, but was with the great increase in cocaine usage that was reported. So that increased about 12-fold between 2019 and 2021. And we don't know why that is. I know the teams on the ground speculate that that could be due to a lack of supply of heroin for the demand during the COVID-related lockdown. And other factors that are not on this slide, but are also brought out from the survey, there may be an increase in the frequency of injecting, more groin injecting as well, associated with that cocaine use, but also no increase in the use of needle and syringe exchange programs. So again, just briefly, some of the outbreak interventions, increased needle and syringe exchange programs, access to treatments, increased case finding in the criminal justice system, and health checks for homeless people, and trying to address, perhaps most difficultly, the underlying causes, so poverty and housing issues. So in conclusion, this was an outbreak that was detected through routine clinical HCV sequencing, and we're currently trying to set up a national HCV genomics database linked to the treatment outcome registry, and we think this will be an important tool towards monitoring progress to HCV elimination. Secondly, this appears to be associated, this outbreak, with increasing cocaine injection, but clearly further intervention measures are needed to mitigate the transmissions. And just very briefly to mention, this was obviously a huge number of people involved in this work, both in England and Northern Ireland. Thank you.
Thank you, Dr. Bradshaw, for your work. Unfortunately, we don't have time for questions because we're on the 5-minute timer. Our next speaker is Professor Pedro Mathieu Jalabert. And if you could come up, please. He's a sociologist in New York City with publications on the epidemiology of drug use, urban studies, immigration, social networks, and HIV and Hep C prevention. Please.
Thank you. It's a pleasure to be here. There is how I can summarize 6 years of work in 5 minutes. So I'll try. I'll probably fail at it, but it's an effort. So as you all know, injection drug use continues to be a major risk for Hep C, and so is in places with high harm reduction coverage, such as New York City. And we develop a staying safe behavioral intervention to prevent hepatitis C for 2.5-hour sessions based on strategies and practices of long-term people who inject drugs in New York and manage to remain uninfected. So the randomized control trial, we recruited 169 participants. The inclusion criteria, eligibility criteria rather, was ages 18 to 29, so young people who currently use opioids or heroin at least 3 times in the past 30 days. Recent injection drug use, at least once in the last 6 months. And another requirement was that at inclusion, they needed to be Hep C antibody negative and HIV antibody negative. Participants were randomly assigned to staying safe, 83 participants, and attention match control of 86. I think it's worth saying here the attention match was quite onerous for ethical reasons, so we were happy to do so. We provided naloxone, an overdose prevention, and we also provided hepatitis C prevention knowledge for those who were in control. Okay, so participants' drug use and injection share practices were assessed at baseline and 4 follow-up periods, 3, 6, 9, and 12 months post-intervention. And the hepatitis C HIV status was tested at baseline and 6 months. This analysis is based on generalized mixed effects, piecewise regression models. Okay, results. Let me tell you a bit about the participants. The mean age is 25. They first start injecting at age 20. Standard deviation 6.2. 27% were women, 31% Latinas, and 55% non-Hispanic whites, and 5% blacks. Quite large population of homeless, 31% at baseline, and 91% met criteria for severe opioid use disorder. And at baseline, 82% share injection paraphernalia in the past 3 months. 77% of participants and 74% in control attended at least one session of the intervention. As a result, compared to baseline, participants in both arms were significantly less likely to share injection paraphernalia other than syringes at all post-intervention points. This is a bit of a graph that kind of represents sharing cookers over the 12 months follow-up. So each column you will see is baseline 3 months, 6, 9, and 12. And the 0 will be the number of people who did not share. And you can see how over time that number of individuals increases while the darker numbers, those who share 6 or more time, reduces. The line represents the means a little bit wild here because we have quite a bit of outliers. But certainly the overall trend is one in reduction in share cookers and in reduction of number of people with whom the participants share cookers. Similarly, similarly for share filters and for number of people with whom the participants share filters. This is a summary of the table. Basically, we don't have a difference between intervention and control, but we do have a significant difference in reduction of sharing equipment and reduction of number of people with people share equipment. Discussion summary, both participants significantly reduced injection risk behavior during the trial. That's good news. And in localities with harm reduction coverage, such as New York, repeated antibody testing and regularly inquiring about sharing practices might be sufficient to significantly reduce injection risk among young people who inject drugs. Wow.
Fantastic, that was well done. Please thank Professor Mature. If you have questions, you can discuss with him after. Unfortunately, the break, we've gone over time. So we'll just invite the next person. Thank you very much.
Thank you.
We now welcome Mr. Isaac Ogunkola. I believe, hopefully I pronounced this correctly. He's a professional and academic background in public health science with an interest in advocating for harm reduction and drug policy reform, nationally and internationally. We'll be talking today about Global Digital Health Hub for HIV. Thank you.
Hi, everyone. I'm Isaac, and then I'm aware this presentation should be 3 minutes, and I'll be as fast as possible to deliver it. Okay, so this abstract is actually an evaluation of a project we did at UTRISE. We are trying to evaluate online harm reduction service provision among young people who use drugs. So we all know that there are higher risk of HIV and hepatitis among people who use drugs. And then in recent times, there's been an increasing use of internet in drug sales, and people access drug information on the internet. And in fact, that was exacerbated by COVID-19. There are cases of accessing drug information and buying and selling of drugs in places like Nigeria, Ghana, Russia during the COVID-19. All right, so it was a workshop, and then we did an evaluation of the workshop using Google Survey, Mentimeter. The Zoom sections were recorded, and then it was analyzed. We did a qualitative analysis of the recordings. And then from our results, we had 15 key populations in their diversity. They are all young people who use drugs. And we had representatives from Ghana, Nepal, Pakistan, Canada, Kyrgyzstan, Nigeria, Peru, Kenya, Costa Rica, Louisiana, Lebanon, Morocco, and Uganda. And one of the key challenges that was highlighted by this young person was the censorship and ban of social media and internet in some countries, which was experienced in Russia and also in Nigeria during the protest in Nigeria. There are some censorship and bans of social media, which could affect online harm reduction service provision. And then in conclusion, our findings highlight that online harm reduction service provision is an approach that harm reduction organizations should imbibe and consider implementing. And then it could speed up delivery of services, it could bypass stigmatization, and then we believe there is more work that needs to be done on the advantages of online harm reduction service provision, particularly in order to make it a youth-friendly service to young people who use drugs. Thank you.
The paper is open for questions. It can be a comment, too, if you're doing similar work in your own area. Just thinking about what you're doing online, do you see a value for online overdose prevention as well in this platform, or is that something completely separate?
Well, I think that could be integrated into the online space. For example, we had a platform, a mobile application called the Trip App, where young people can evaluate the drugs in their community, test them, and then give information to other young persons who use drugs in their community on those drugs and the quantity they need to take, if it is adulterated or not. So I think it could be useful in that regard as well. Thank you.
Thank you very much.
Yeah. All right.
La prochaine personne qui va nous parler est Dr. Félicienne Yomi Tiea. Si vous voulez aller ici, c'est accès aux soins des femmes usagères de drogue à Côte d'Ivoire. You can use your headsets for translation, because if you just, maybe we should have gone through that beforehand.
Merci de me donner la parole. Je suis Félicien. Je viens vous partager l'expérience de mon association Parole autour de la santé à travers l'accès aux soins des femmes usagères de drogue en Côte d'Ivoire. Pour le contexte, on dit qu'en Côte d'Ivoire, les femmes usagères de drogue vivent une vulnérabilité sociale et sanitaire du fait de l'absence de propositions adaptées des services de santé. elles sont stigmatisées et discriminées, surtout celles qui sont enceintes. Au regard de ce constat, nous, on a mis en place un projet afin de leur permettre d'avoir accès aux services de santé. Mais pour y arriver, nous avons formé 5 pères éducateurs issus et reconnus par la communauté sur la physiopathologie du VIH, sur le dépistage et les pratiques à risque. Et au sortir de ce projet-là, nous avons sensibilisé, dépisté 299 femmes usagères de drogue, dont 3% étaient infectées du VIH, elles ont été mises sous traitement. Nous avons une cohorte de 40 femmes usagères de drogue qui sont suivies régulièrement à travers les groupes de parole. Et nous avons suivi 7 femmes usagères de drogue, dont 5 ont accouché, 2 par césarienne. Nous avons facilité également l'accès aux activités génératrices de revenus à 5 femmes usagères de drogue. Et les photos qui sont là, les images là, illustrent un peu ce que nous venons de dire. Les enfants qui sont nés des mères usagères de drogue, nous avons récompensé les femmes usagères de drogue qui ont leur carnet de santé à jour. Ici, il s'agit des séances de dépistage et de visite à domicile des femmes usagères de drogue infectées du VIH. Les femmes usagères de drogue anciennes que nous suivons, les sensibilisations de masse, tout ça. Et c'est les activités que nous faisons, nous référons les femmes usagères de drogue, nous prenons en charge leur traitement. Au regard de tout ça, nous avons des difficultés. Les femmes ont du mal à faire leur CPN et les vaccins de leurs enfants. Elles ont du mal à se nourrir, à nourrir leurs enfants. Elles ont également des problèmes de dortoir. On assiste à des décès postpartum, des abandons de bébés et elles sont rejetées par la famille. Et nous, on propose de trouver un centre d'hébergement pour les femmes enceintes et les enfants nés de mères usagères de drogue. Il faut développer aussi la médiation familiale pour permettre aux usagères de drogue de retourner en famille. Il faut les aider à l'obtention des produits hygiéniques parce que lors de leur période de menstruation, elles ont des difficultés. Il faut trouver des financements pour y arriver. Et la leçon que nous apprenons à travers notre projet, c'est que quand on implémente un projet avec la paire éducation, cela a un impact véritable sur la population parce que la population usagère de drogue adhère. Et donc, parole autour de la santé dans un contexte de répression à l'usage de la drogue arrive à asseoir sa légitimité à travers ses activités. Il est important que nous la soutenions. On retient aussi que la prise en charge des femmes usagères de drogue reste un parent pauvre dans la politique nationale de prise en charge des usagers de drogue. Nécessité de mettre en place des projets innovants pour accompagner les femmes usagères de drogue. C'est sur ces propos que je m'arrête. Excusez-moi, je n'ai pas pu parler l'anglais parce que je ne parle pas l'anglais. Et donc, j'ai dit ensemble, il faut qu'on promeut la prise en charge des usagers de drogue pour leur permettre de bénéficier aussi de leurs droits. Merci.
Docteur Tia, ouais, on a déjà fait des connaissances, je suis là. J'ai eu déjà l'opportunité d'en parler avec vous et votre projet me semble super intéressant. Je voulais demander en termes de la possibilité d'avoir des autres financements pour soutenir le type d'activité que vous avez décrit. Est-ce que vous avez la possibilité d'avoir des financements dedans le Côte d'Ivoire, ou est-ce que vous pensez que ça va être vous allez être obligé de chercher à l'étranger, ailleurs de la Côte d'Ivoire, la région de l'Afrique de l'Est, pour pouvoir continuer avec ce type d'activité?
Merci. Au niveau local, généralement, c'est difficile pour nous d'avoir des financements. Donc, ce que nous, on fait, c'est de voir avec les partenaires extérieurs, notamment SIDA Action de la France, qui nous accompagnent dans le cadre de nos différentes activités. On est en quête aussi de financement parce qu'au niveau local, c'est difficile pour avoir les financements. Donc, nous, on essaie un tant soit peu de pouvoir voir avec les partenaires qui sont intéressés sur la thématique et de nous accompagner afin que nous aussi, on puisse accompagner les femmes usagères de drogue.
Merci bien.
Merci.
Okay. Our next speaker is Jordan Killen, who I met on the train on the way here. She's going to speak to us about her MPH and PhD work with with Natasha Martin.
Thank you. Well, thank you for allowing me to present this research today. I'm going to be talking about modeling the impact of supervised consumption sites on HIV and hepatitis C transmission among people who inject drugs in 3 California counties. This is my funding and disclosures. So supervised consumption sites are where people who inject drugs can bring their previously obtained drugs and consume them in a supervised setting. They've been shown to reduce syringe sharing and overdose. They're used in several countries worldwide. Within the US, there's only one company running 2 sanctioned supervised consumption sites in New York City, and they started in 2021. In 2022, the governor of California vetoed a bill that would have piloted supervised consumption sites in California. Since then, the mayor of San Francisco has moved forward to try and implement supervised consumption sites through the same funding mechanism that's used in New York. There have been no studies that look at the long-term benefits of supervised consumption sites on HIV and hepatitis C prevention in California. So we look to examine the impact of implementing supervised consumption sites at 20% coverage on HIV and hepatitis C transmission in 3 California counties, San Francisco, Los Angeles, and San Diego. We did a dynamic deterministic compartmental joint model of HIV and hepatitis C transmission among people who inject drugs. We accounted for sexual and injection-related transmission of HIV and injection-related transmission of hepatitis C. We calibrated to the HIV prevalence in 2018, the HCV prevalence in 2015 and 2018, the proportions of infections due to sexual transmission, and ART coverage among people who inject drugs in 2018. For the intervention effect, we looked at those had a estimate from an unsanctioned supervised consumption site within the US that showed that the relative risk of receptive syringe sharing among those in contact with the supervised consumption site is 0.17. And we modeled 2 scenarios. One is the status quo with 0% coverage of supervised consumption sites, and the second is scaling up supervised consumption sites to 20% coverage among PWID in these counties. Overall, looking at a 10 years post-supervised consumption site of 20% scale up, we found that within San Francisco, the supervised consumption site could prevent up to 22% of new HIV infections in San Francisco, 15% of new HIV infections in Los Angeles, and 14% of new HIV infections in San Diego. And looking at hepatitis C transmission, 28% of new hepatitis C transmissions in San Francisco could be prevented, 32% in Los Angeles, and 27% in San Diego. Overall, there were several limitations to the study. We didn't account for heterogeneity among PWID due to lack of data availability. We also had wide uncertainty estimate in our relative risk for this reduction in receptive syringe sharing for supervised consumption sites, so that drives uncertainty in our model projections. We also had uncertainty in future drug trends, as there's been several literature showing that there's been a shift from injection drug use to smoking fentanyl in California. And then we also didn't account for we didn't account for other benefits of supervised consumption sites within this model. Overall, though, despite these limitations, we were able to establish that supervised consumption sites can prevent 14 to 22% of new HIV infections and 27 to 32% of new hepatitis C infections among PWID in these 3 California counties over 10 years. The research can help strengthen evidence to implement supervised consumption sites with the policies and the ongoing conversations regarding supervised consumption sites within California. Thank you.
Well done. Fantastic. Thank you so much to Jordan. We have a moment for a question from the audience. If anyone's interested, we've got one hand in the middle for you.
Yeah, quick question. Ben Eckhart, great presentation from New York. Just from the New York perspective, I think there's been some modeling studies that suggest New York City needs 7 supervised consumption sites to have its maximum effect, and you mentioned we only have 2. Do you have a sense of, for these 3 California cities, to reach that 20%, how many sites would actually need to be opened?
No, we didn't look at the number of sites that would be needed, just versus like 20% for the population. So unfortunately, I don't have that answer for you.
Fantastic question. Thanks, Jordan, for a wonderful presentation. And thank you all for staying with us for the final presentation today. We're only a few minutes over. The final presentation today is Dr. Stina Hui from Montreal, who has a social epidemiological background with an interest in substance use, drug-related harms, and access to healthcare services. Thank you.
Thanks, Brendan. So for quite logical reasons, I think unpredictable and chaotic life circumstances and inadequate social support might increase the risk of drug-related harm and the ability of people to navigate health services. But there's actually not a lot of research looking at these constructs in the population of people who inject drugs. So we sought to identify correlates of life chaos and social support among people who inject drugs in the province of Quebec in Canada. The data come from the Virtual Cascade of Care cohort study. A primary aim of this study was to assess uptake of HCV treatment among people who currently and formerly inject drugs. So the eligibility criteria were a lifetime history of injection drug use and any illicit drug or heavy alcohol use in the past 6 months. Participants were recruited via community-based harm reduction services in 3 cities, so Montreal, the biggest city in the province, and then Trois-Rivières and Sherbrooke, which are smaller cities with a population of about 150,000. And the main procedures in this study are an interviewer-administered questionnaire, and we also have a follow-up of health service use via administrative databases, which I won't talk about today, but it's in the poster, if you want to come and see the poster afterwards. So the sample for this study is 195 people, including 75 recruited in Montreal and 120 recruited in the smaller cities. Median age of 43, predominantly men, and around 70% had injected in the past 6 months. A quarter had injected daily in the past month, and around a quarter were receiving opioid agonist treatment, with relatively high levels of self-reported homelessness and incarceration in the past year. So the measures we used, these are all taken from the interviewer-administered questionnaire. Life chaos was measured using a 6-item scale that captures a general sense of organisation and stability in the participant's life. This was validated among adults living with HIV in Los Angeles. And we have a 10-item scale of social support that's drawn from the social provision scale. So there's 2 items capturing 5 different provisions or benefits that you get from social relationships, such as attachment, social integration, those types of things. And that one was translated into French and validated among general population adults in Montreal. We also have a range of covariates that are sociodemographic, substance use, and related to health and service use. The time periods differ a little bit, but generally they're capturing things in the last month, the last 3 months. So we analysed this within a structural equation modelling framework. So essentially it takes 2 steps. The first was to confirm the measurement models for each of the scales separately, and then the measurement models for them combined together. So essentially we're extracting latent factors that represent life chaos and social support based on the observed indicators in the questionnaires. And then we expand this model to add our covariates so that everything is estimated simultaneously in one model for both outcomes. So briefly, the predictors of life chaos and social support were quite different. Life chaos was, I would say, more easily predicted and more associated with a lot of the measures that we usually collect. So recent homelessness, daily injection, stimulant use, and hazardous alcohol use, which was measured using the Audit C. Social support was inversely associated with age, and also with it was lower among people who reported an overdose in the past 3 months. Both of the measures were associated with past year self-reported unmet healthcare needs, and life chaos was associated with a global self-rated health measure. So in conclusion, these could be interesting measures to use as kind of proximal outcomes for intervention trials, and I think our results kind of say that investments in a lot of the things that we usually look at, like stimulant use, alcohol use, and also interventions promoting social support more directly might be beneficial to improve quality of life in this population. Thank you.